Thank you very much, Professor Citterio, for this very important lecture that introduces several key issues in the future management of ACC. And thus we have 15 minutes to open the discussion for this first part of the webinar. I don't see any question in the chat room. I invite all the speakers to send a... Okay.
Yeah, we received the questions from Professor Ramadori and Professor Larritt, and I send the questions to you.
Thank you all for the very interesting talks. I have a question for Patricia Burra and Dr. Schwartz at the same time. It concerns the role of HCV in liver disease. And I just would ask your opinion about, there is a change. There's been a change between, the time before discovery of HCV, where people got HCV through blood unit. People got blood unit and HCV as a load. And they developed most probably a liver cirrhosis really through the HCV. And after elimination of the units of HCV positive units, people got HCV maybe by drug addiction. And the amount of HCV was much lower, and maybe the development of liver disease was due to cofactors. Maybe it's possible that you get, a less advanced disease through the HCV, and you are surprised that, the HCV positive get a better outcome?
I can answer that from my perspective. I agree with what you say. I was struck when I went to Japan and observed liver surgery in Japan, where the predominant etiology is clearly hepatitis C-related HCC, that the livers and the course of the surgery really looked like what we're used to seeing in our Asian patients in New York with hepatitis B, whereas our patients with hepatitis C, for the most part, as you described, are patients from in New York, the community of Harlem, where there's a high rate of obesity, diabetes, alcohol, and I think we label the patients hepatitis C because it's easy to do the serologic test and have a result and say that's a hepatitis C patient, when in fact it's a mixed etiology. So that I don't doubt that pure hepatitis C related HCC is different from what I'm used to seeing and calling hepatitis C.
Actually, if I may add to this comment from Professor Ramadori, when we debated quite a few years ago, the results of survival of 24,000 patients transplanted for either hepatitis C, alcohol, HBV, then we found that it was not easy, a subgroup of alcohol plus hepatitis C, or vice versa, hepatitis C plus alcohol consumption. Actually, that category was the ones having the worst survival. So if we really combine the different risk factors, that was in times just before the issue of NAF or the NASH. Now the story maybe is different, but you're right. It is important that the classification that we have in the notes, or the classification that we have in different registries, is not sometimes so accurate to have all the different factors. And I think, for example, adding on today, the diabetes makes the difference. The presence of diabetes, either in the alcohol, hepatitis B, hepatitis C, the risk not only of HCC, but also the risk of other tumors. And we don't pay attention that much. So your point is very well taken.
Yes, thank you, Professor Burra. I fully agree with you on this point. And the second question is coming from Professor Leroux. The question, I think, may be sent to both Professor Schwartz and Professor Citterio. And the question is, the results after liver resection and transplantation are expressed in overall survival. But it is not time to only speak about disease-free survival rate. It's a really challenging issue. Please, Professor Citterio and Professor Schwartz.
Yes, thank you. Well, if I get the point, I think that I believe that actually overall survival is still the hardest endpoint, because and that's where we observe the big difference between liver resection and liver transplantation, because we can have very good results with liver resection for HCC, but we observe at least after 5 and even more than 5 years after resection, we can observe a recurrence or progression of cirrhosis leading ultimately to death. And so in my opinion, overall survival is still the most important endpoint for these patients.
Yeah, I think we're viewing HCC more as a chronic disease that needs to be managed over time. And in fact, I think what you do for the index tumor, whether it's resection for an early tumor or a non-surgical treatment, is maybe not the major determinant of outcome. And following the patients and treating recurrence is the key to long-term survival. And for me, I would rather have a tumor treated and have it recurred and be treated again than have a liver transplant, because a liver transplant is no bonus. The life after liver transplant is different. The life expectancy after transplant is affected by the transplant. And so that I think that dealing with it as a chronic disease, accepting recurrence, following closely and treating recurrence, especially now that hepatitis C is cured and the livers don't tend to deteriorate in other ways, is probably, well, it's a strategy that we're adopting more and more.
Professor Leroux, do you want to a short reply?
Yes, I want to reply. So the reason of my question is that if you take the overall survival as your strongest endpoint, this gives for me a lot of confusion and explains, in my opinion, why there is still so much debate about liver resection, liver transplantation, radiofrequency, chemotherapy, immunotherapy, and so on, because you can have one treatment, you recur, and due to the progress in other treatment modalities, you can prolong survival a lot, but it does not allow you to finally give an exact view which therapy or which primary therapy is the best one. And if you look, for instance, at the famous Barcelona scheme, you remember that on the bottom line, it's only set the median survival for every stage. But of course, now with you can do a radiofrequency, you have a recurrence, you can do maybe immunotherapy, maybe you can do resection, and at the end you have a long overall survival. But at the end, it's a patient who has a cancer, and a cancer patient who is not cancer-free has always a lot of problems, psychologically, medically, and so on and so on. So I personally think that we must express much more the results in disease-free survival than in recurrence-free survival. Than in overall survival, excuse me, than in overall survival. Sure. That's my opinion.
Sure. This is a very important point of view, and probably the future studies may better discriminate if there is a real difference in the future trials between these two endpoints. So we have more 5 minutes, I think. If there are no any questions coming from the audience, I will to ask to Professor Burra how to improve, in your opinion, the selection of patients with NASH who have a risk of ACC, who are generally followed by diabetologists instead of the hepatologist, almost in Italy and I think also in Europe. I think that many patients with harbor the risk of ACC in their liver are not still followed by an hepatologist. What is your opinion?
I think this is a crucial point. And actually, we discussed about this integration of, let's say, knowledge and skills in the commission that we had with ISO, Lancet ISO Commission. That was one point. We all are believers, hepatologists are believers in the integration of different specialties. And however, that's in the practical thing and daily practice, let's say. It's not easy, it's not common to have a collaboration with diabetologists. So I think it should start from us. Surely we should make a better knowledge about the general practitioners to understand that having the diabetes or having the obesity or having the arterial hypertension might be associated with liver disease. So I would really start from that position, not from our specialists that try to defend probably their own category, but I would really start with better knowledge and understanding from the GPs. That's for sure. We'll have the first level or check it. Maybe you just ask for the ALT, that's it. We don't need so many examinations. If we have one ALT, one liver function test, and ultrasound, that's it. We're done. This is my opinion.
Yeah, I fully agree with you. The last question, I think, to Professor Schwartz. You have clearly illustrated the changes of the etiology and the typology of patients with ACC in your center. So my question is, have you changed your pre-surgery evaluation of patients with ACC? In other words, for example, do you perform a more accurate studies on the cardiovascular function compared to the past before to perform the surgery in these patients with NASH or not?
We really haven't changed our protocols in terms of preoperative testing. We've always been very careful about that because I think to demonstrate an advantage of surgery over non-surgical treatments in general requires having basically no morbidity and mortality as the result of factors like cardiovascular disease. You have to select the patients well and have good early results in order for those treatments to have advantage. So that we've always routinely for people past 50s done stress testing and so forth. And we haven't made any particular change related to the NASH patients, but more of them are ruled out than patients with other etiologies.
Yeah. So I think that we are in time to open the next session. I would like to thank very much all the speakers that participate to the first section. Obviously, all of them are invited to participate to the second session if is possible, obviously. And I would like to open the second section of the webinar with Professor Umberto Cillo from Padua in Italy, who will speak about the new horizons of downstaging treatments before liver transplant. Please, Professor Cillo.